Medical director requirements have no single national rule, and guessing wrong shows up in surveys, credentialing, and payer reviews. No national rule. Requirements vary by service line, payer model, state licensing rules, and whether your program includes medication services. Operators keep searching for one answer to, do I need a medical director? The honest answer, it depends on your program, but there are clear anchors. In the next few minutes, when a medical director is most likely required, the questions to work through early, and a better way to staff the role. Start with the anchors that are explicit. For opioid treatment programs, SAMHSA's OTP guidance and the federal certification rule at 42 CFR 8.11 make medical director oversight explicit. Outside OTPs, you review state licensure rules, accreditation standards, and the actual services you offer. California's DHCS ties licensure to specific services and levels of care. Florida's DCF runs its own licensing system. These questions are answered at the program and state level. Here is the stakes question. If a regulation or payer contract expects physician oversight, a name on paper is not enough. Regulators and accreditors usually care about the actual duties, authority, and availability, not the title. When you cannot show how clinical oversight actually works, surveys, credentialing, and payer reviews all get harder. So, when should you assume medical director review is needed? When your program includes any of these: medication management or detoxification, OTP services, or incidental medical services, physician-supervised clinical protocols, or a licensure category that explicitly requires physician oversight. Many operators review staffing and technology together, because once medical oversight becomes more formal, the platform supporting the team matters. If your program depends on fast chart review, outcome tracking, and physician sign-off, the workflow has to keep up. Behave Health's platform is designed to support exactly that kind of workflow for PHP and other formal oversight programs. Before you assign a title, work through 3 questions early: what you deliver, what the role really is, and how coverage works. Question 1. What services are you actually delivering? A counseling-only outpatient program may have very different leadership requirements from a detox, OTP, or program delivering medication services. Define the service model before you assign titles. Question 2. Is the role clinical, administrative, or both? Some organizations use medical director to mean a clinically accountable physician leader. Others use it loosely for part-time chart review or policy oversight. What counts is the actual duties, authority, and availability. Question 3. How does coverage actually work? You need a plan for absences, delegation, and after-hours issues. And for documentation review, so you can show oversight is real, not just named. Even when rules differ, define the core responsibilities up front. The scope of clinical authority: medication policy oversight and protocol approval, supervision or consultation expectations, and quality review responsibilities. And reporting lines into executive leadership. That makes surveys, credentialing, and payer reviews much easier. The right medical director structure starts with the level of care. A PHP or IOP program may need a different physician presence model from a detox or OTP. Start with state rules and service design, then build staffing around the actual operational need, not a generic checklist. Stop guessing at medical director requirements from a generic checklist. See chart review, outcome tracking, and physician sign-off workflows, and compliance consulting that coordinates with your counsel. Book a 20-minute demo at behavehealth.com.